morning everyone. So I welcome you all to this free paper session, and we'll be starting with the first free paper. And do we have Dr. Rita here? Okay. Yeah, so we can start with Dr. Payal. So it will be better if you stick to the time limit, right?
Second.
I think it's 5 minutes.
Yeah, 5 minutes.
5 minutes, sir. I think the free paper instructions.
Okay. Good morning, respected judges and delegates. Today I am here to present my paper on orbital tuberculosis, which presented as proptosis. So, there is no financial interest or conflict of interest, and proper patient consent has been taken. Giving brief introduction, orbital TB is a rare form of extrapulmonary tuberculosis, also in endemic areas. Cases of ocular TB are increasing, but eyelid as well as orbit are usually not involved, and primary infection of orbit or eyelid is a rare occurrence. So going to my case, a 53-year-old male presented with swelling of right lower eyelid and diminution of vision right eye for 15 days. And there was restriction of movements in all directions of gaze in right eye and bulging of right eye eyeball forwards, upwards and medially, which was associated with headache and nasal blockage. As we can see in the pictures, there is marked conjunctival chemosis and evident proptosis. So patient is diabetic and takes medication irregularly, but gives no history of cough, fever or weakness. There was no associated hypertension or thyroid disorder. There is no history of ocular surgery or ocular trauma in the past. On examination, visual acuity was hand movement in right eye and best corrected visual acuity in left eye was 6/9. There was conjunctival injection and high IOP, and fundus showed pale optic disc right eye with macular exudates in both the eyes. As we can see in fundus picture here, there is pale optic disc and some macular exudates. On investigations, among significant findings, RBS was 152, ESR and CRP were raised, Montes test was positive, chest X-ray was within normal limits. CT nose and PNS was done, which showed soft tissue thickening, which involved extracorneal compartment of right orbit, but it was extending to orbital apex as well as right cavernous sinus, sphenoid sinus, and right maxillary sinus with some bony erosions. And after that, MRI brain with contrast enhanced MRI orbit was done, which showed extensive enhancing mucosal thickening and inflammation, which involved right maxillary sinus, and it was extending into the right orbital apex and optic foramen, and there was resultant compression of right optic nerve. So histopath from inferior turbinate was taken as patient complained of nasal blockage, so it was examined by ENT department and they took a biopsy which showed mixed inflammatory cellular infiltrates, lymphoid, lymphoplasmacytoid, histiocytoid, neutrophilic and eosinophilic cells with few epithelioid histiocytoid-like cells and multinucleated giant cells. So it was a granulomatous inflammatory cellular lesion of probable tuberculous origin as per histopath report. So among diagnosis and management, proptosis right eye due to orbital tuberculosis diagnosis was made, and with pulmonologist and neurosurgeon's opinion was also taken as there was intracranial extension and they advised no surgical intervention. So patient was put on anti-tubercular therapy, 4-drug regime with pyridoxine and multivitamins. Patient responded well to the treatment and swelling subsided, as we can see in the pictures. First one is after a few weeks of treatment and lower one is after 2 months of treatment. With visual acuity was hand movement in right eye, it was at presentation the same due to resultant optic atrophy. So MRI was also repeated and there was reduction in this disease process. These two MRIs were taken at 2 months interval. So, in discussion, similar cases have been reported earlier. So, like by Abhijit Kaur et al. In June 2005, in a 17-year male, where patient responded to 4-drug ATT. And another case was reported by Hyun Sik Yoon et al. In August 2019, in an 18-year-old female, where also patient responded to ATT. So concluding, high index of suspicion is really required for diagnosing orbital TB, and early diagnosis and management is very necessary to salvage the eye and sometimes to save the life of the patient. These are my references. Thank you.
You have given ATT for how much duration?
6 months.
This is a orbital case with extension to cavernous sinus.
Yes, yes, sir.
So I think the duration should be at least 9 months. Have you taken a consultation from the?
We took consultation from pulmonary medicine department, and as per their advice, we only gave. It was not, duration was not advised from
Have you
our
done
side.
a abdominal ultrasound?
Sorry?
Chest X-ray was normal.
Chest
you have
X-ray
not
was-
done HRCT.
HRCT was also normal, sir. It was done.
Abdominal ultrasound?
Abdominal ultrasound patient showed some features of pancreatitis, nothing else. It was treated by medicine department.
But histopathology was also not conclusive, but the patient responded to ATT.
Yes, patient responded to ATT very well.
Presented. Okay, thank you.
Thank you.
Are you presenting the next case also?
Yeah, I have one more.
You can go on.
Okay.
Right.
So may I start? Okay. So I'm presenting another case of isolated eyelid schwannoma which presented as lid mass. There is no financial interest or conflict of interest, and proper patient consent has been taken. So giving brief introduction, schwannoma is a benign tumor and rarely malignant, and it originates from Schwann cells which form the neural sheath of the sensory nerves. Most common areas are nerves of head and neck, but except the ophthalmic ones, and primary schwannomas in ophthalmology are very rarely reported. So going to my case report, 29-year-old female presented with swelling of right upper eyelid for the past 10 years. It was gradually increasing in size, which patient neglected, not associated with pain, redness, watering, or diminution of vision. Here, as we can see in the picture, there swelling can be seen. There was no history of ocular surgery or ocular trauma in the past. On examination, visual acuity was 6.6 in both the eyes. Extraocular movements were full, free, painless in both the eyes. And in right eye, eyelid had a swelling of 2.3 into 1.3 into 1.2 centimeter, and rest of the anterior segment examination was within normal limit for both the eyes. So going to the swelling, it was a well circumscribed swelling of previously mentioned dimensions, firm in consistency, freely mobile, non-tender, with no attachment to the overlying skin, with no skin changes, and it was also not attached to the surrounding structures, and there was no restriction of extraocular movements, and no ptosis was associated. In management, X-ray orbit was done and it was within normal limits. Patient was planned for surgery after doing routine investigations, and lesion was excised as en mass by giving incision as at eyelid crease, and the mass was sent for histopathology. So histopath report came out to be this. It was a whitish, homogeneous and walled specimen which showed capsulated mass comprising of hypercellular and hypocellular areas of plump spindle cells with spindled cytoplasm and oval to elongated bland nuclei with nuclear palisading varicose bodies and scanty stroma, which are the features of schwannoma. So patient is completely free of symptoms post-operatively with no recurrence on 6 months follow-up. In discussion, in most of the cases, schwannoma manifests as a single neoplasm, and presence of multiple schwannomas are indicative of neurofibromatosis 1 or 2. Our case was an isolated lesion of eyelid having no systemic disease. And schwannoma in lead is very rare. Just few cases have been published, and age range in the reported cases matched with our case report, and size of the tumor in our case matched with the tumor size range reported by Sudhir et al. In differential diagnosis, there are dermoid cyst, inclusion cyst, and chalazion. Only with excisional biopsy, we could get the final diagnosis. As in our case, we could get the final diagnosis with the biopsy. So concluding, accurate histological diagnosis and early complete excision of the tumor should be the objective in managing the schwannoma of the eyelid. Schwannoma should be considered in differential diagnosis of a well circumscribed swellings of the eyelid. These are my references. Thank you.
You are not a ratified member, right? Okay. Thank you.
So do we have Dr. Manjeet Boro here? Yeah. So he'll be presenting on the asymptomatic optic disc melanocytoma.
Hello, a very good morning to everyone present here, to respective judges and the distinguished delegates. So today I'm going to present my free paper on asymptomatic optic disc melanocytoma, a case report, myself, Dr. Manjeet Boro. So there is no financial support and sponsorship. So going with introduction, melanocytoma is a rare, benign stationary tumor which appears as a pigmented lesion on the optic disc. It may develop wherever uveal melanocytes are present and most commonly occur on or adjacent to the disc. Optic disc melanoma can compress the optic nerve or undergo necrosis, leading to ischemic axonal loss and visual field defect similar to glaucoma. It displays a diagnostic dilemma due to its similarity with melanoma. They are typically unilateral and rarely undergo malignant transformation. Progressive growth and malignant transformation can be documented by closely monitoring the patient's eye. Considering its rarity, we report a case of optic disc melanocytoma. So my case goes like, a 40-year-old male came to outpatient department for medical fitness certificate to apply for a government job. He did not have any complaints of both eyes. On ocular examination at our institution, his visual acuity was found to be 6/6 in right eye and in left eye it's 6/9, which got corrected with -0.5 diopter. The anterior segment of both eyes in slit lamp were found to be normal. The intraocular pressure and color vision of the patient was within normal limit. So on fundoscopy, the right eye fundus showed clear media with blackish elevated mass lesion with approximately 1 disc diameter with feathery margins and was obscuring the optic disc and extended to inferior medial quadrant. There is no retinal edema, disc edema, or subretinal fluid. The left eye fundoscopy appeared to be normal. So this is my fundoscopy photo. The fundoscopy findings were later confirmed with fundus photography and OCT of optic nerve head. OCT optic nerve head showed a lobular dome-shaped elevated mass with a dense posterior shadowing. So this is the picture of the OCT. It's showing a dense lobular dome-shaped mass. So 24 days to perimetry of right eye, it's normal. So general and systemic examination revealed no abnormalities. On the basis of characteristics, location, and clinical features, a clinical diagnosis of optic disc melanocytoma was made. The patient was asked for regular follow-up for visual acuity, fundus photography, and visual field for noting the increase in size of the lesion or any alteration in the visual field. So in discussion, in retrospective analysis of 115 patients, Shields et al. Found that 99% of patients present with unilateral lesions and 100% presented with hyperpigmentation. So tumors average 2 mm in diameter and 1 mm in thickness. So in our present study, the patient showed a similar pattern with a black mass of approximately 2 mm in the optic disc of the right eye, protruding from its surface and obscuring some retinal vessels. Gupta et al. Documented clinically typical melanocytoma that grew progressively for 6 years without any documented malignancy. Shields et al. Analyzed OCT of 15 optic disc melanocytoma cases showing hyperreflectivity on the anterior surface of the tumor and dense posterior shadowing in all cases with an optically cavernous appearance. So there may be some common visual field defects like enlargement of blind spot and nerve fiber bundle defect. It has been defined that the enlargement of the blind spot is related to the number of tumors extending to the edge of the optic disc. However, in our case, the visual acuity of the patient's left eye was normal and visual field defects were not found. As referred above, optic disc melanocytoma is a benign tumor that may grow slowly and rarely transforms into a melanoma. Being the rate of malignant transformation of 2%, there is no established treatment of melanocytoma, and observation is the only clinical tool for its management. So hereby I conclude, the present case highlighted the importance of identifying optic disc melanocytoma in an asymptomatic case. So it grows very slowly over several years or remains stable, in contrast to malignant melanoma. Though optic disc melanoma tends to have a benign behavior, it may adversely affect visual function. So therefore, fundus examination is necessary for monitoring the growth and detecting malignant transformation yearly. Visual loss can occur due to optic neuropathy or retinal vascular obstruction. So appropriate consent has been taken from the patient and there are no conflicts of interest. These were my references. Thank you.
What is your message from this presentation?
Sir, my patient came just for certificate, for medical certificate, sir. So he's totally asymptomatic. His vision is also 6/6 and in his right eye. That is the abnormal eye. He has vision 6/6. So we should do proper examination from anterior segment to posterior segment to look any abnormalities. If we get 6/6 vision, then we normally tell the patient give the certificate with just color vision or do the normal testing. But we have to properly see the posterior segment also. There may be some finding. So we got the case like this one in our OPD. So
the message is even if the patient comes for a certificate,
yeah, we have to
do complete ophthalmic
yeah,
examination
complete ophthalmic examination
before issuing a certificate.
Yeah.
Thank you.
Thank you, sir.
Thank you, Dr. Manjeet. So now can we have Dr. Ambasta Anita?
This is there listed.
Yes, sir. This one, sir.
Dr. Anita is not here.
Because sir, confusion was there. They have mentioned it in Guru Govind.
So Dr. Subra Jyoti.
Yes, sir.
Please.
I'm here.
Yes, please. Happy to help you. So now these are the non-ratified members who are presented. So no
Okay,
need
you
to
can
mark
start.
them.
Yeah, sure.
From now, I think you can start.
They are not here, so we are moving on to this.
Yes. Subrajyoti Man. Yeah, you can start.
Good morning,
Yes, sir.
respected teachers and my delegates.
Yeah,
Today I am going to present a case report on unilateral optic disc melanocytoma.
present it.
So
But not
I have no
too
conflict of interest and no financial support and sponsorship. So beginning with the introduction, as mentioned, the term melanocytoma was first coined by Zimmerman in 1962, who described it as a benign asymptomatic hematomatous tumor arising from melanocytes. It's a rare ocular pigmented cell tumor which commonly involves the optic disc, and its commonest presentation is in the 5th decade of life with a female preponderance. And most of these melanocytomas do not usually cause a significant visual impairment. 93% of cases had presenting vision of 25/40 or even better, and visual field loss has been reported in few cases. Malignant transformation has been found in 1 to 2% of cases, hence necessitating long-term follow-up. So my case report, it's about a 44-year-old female who came with a complaint of gradual painless diminution of near vision in both eyes for 2 years. The best corrected visual acuity of right eye was 6/12 and near vision in right eye after correction was N8. Best corrected visual acuity of left eye was 6/6 and for near vision it was N6 after correction. Anterior segment evaluation of right eye was within normal limit. The pupil in right eye was round, regular and reacting to light. No RAPD was observed in right eye. Intraocular pressure in right eye was 12 millimeters of mercury measured by Goldman's applanation tonometry. The fundoscopy of the right eye revealed an elevated, well-defined, hyperpigmented brownish lesion with feathery margins in the optic disc region. A fundus autofluorescence was done, which revealed hypoautofluorescence corresponding to the pigmented mass on the optic disc, and a fundus fluorescent angiography revealed a hypofluorescent mass in all the phases. So this is my fundus photograph. As you can see in the right eye, there's a well-defined hyperpigmented brownish lesion with feathery margins in the optic disc region. The left eye's funduscopy is well within the normal limit. We did a spectral domain OCT which showed distortion of the optic nerve head anatomy with presence of a dome-shaped elevated mass lesion. The outer thin layer of that mass lesion was hyperreflective, which may be due to the melanin deposit, with abrupt and complete shadowing behind, obscuring all the details of the optic nerve head. A B scan of the right eye showed a hyperechoic small dome-shaped lesion, which was 1.8 millimeter in thickness with 2.0 millimeters into 1.6 millimeters base over the disc. And Humphrey's visual field perimetry 30-2 showed mild enlargement of a blind spot. All the above mentioned investigation modalities helped us in the diagnosis, as these features were consistent with melanocytoma of the optic nerve head after excluding various differentials to reach the final diagnosis. A follow-up period for 1 year was uneventful. So this is my OCT picture. You can see that the anatomy of the optic nerve is distorted, and the outer layer, as I mentioned, is very hyperreflective with abrupt and complete shadowing behind. Now these are my possible differentials that I had kept after my diagnosis, before reaching my diagnosis. So one was a choroidal melanoma, which is very clinically very difficult to differentiate, but if we use B scan and fundus fluorescent angiography or an enhanced depth imaging OCT, we can get the characteristic features like B scan has a dome-shaped mass with acoustic hollow zone within the tumor. FFA and ICJ will show a double circulation pattern, and in enhanced depth imaging OCT, there will be optical shadowing and thinning of overlying capillaries and subretinal fluid. Choroidal nevus was unlikely because it's a flat and minimally elevated and lies usually outside the optic disc. Retinal pigment epithelium hyperplasia, there's no history of ocular trauma or inflammation, and usually these have irregular margins associated with chorioretinal scarring. Combined hamartoma of retina and the retinal pigment epithelium usually have a juxtapapillary location, and they're usually associated with retinal gliosis, which can lead to traction, and there will be stretching or corkscrew vascular changes. The adenoma of retinal pigment epithelium, usually they appear yellow to orange in color, and they usually have no feathery margins. And a metastatic melanoma to the disc, they usually grow very rapidly, diffusely infiltrate the disc, and the disc may appear as that one in papilledema or papillitis, and a distinct black mass is usually not seen. So none of these features were persistent with whatever we had. So we reached a final diagnosis of optic disc melanocytoma. So coming to the discussion, as I mentioned, it's a hamartoma consisting of large, uniform, round, or oval, heavily pigmented melanocytes. In a study conducted by Lee et al., 93% of the cases had a presenting vision of 20/40 or better. And RAPD was only present in those with 20/50 or worse. Possible complications, very important, include local compression of the optic nerve, exudative retinal exudation, juxtapapillary choroidal neovascularization, tumor necrosis, CRVO, or malignant transformation in 1 to 2% of the cases. Visual field abnormalities include enlargement of the blind spot or nerve fiber bundle defects. As mentioned, very few documented cases of optic disc melanocytoma have been reported in the world literature, and still few cases from India. So assessing the characteristics of this rare tumor with reasonable degree of certainty from clinical entities like malignant melanoma, which have aggressive nature and poor prognosis, so as to avoid erroneous enucleation and prevent systemic metastasis of utmost importance. So these are my references. Thank you.
This is just a case report you wanted to show.
Yes, sir.
What is nobility in your case?
Sir?
What is nobility in your case?
Sorry, I couldn't hear.
What is new in your case?
Sir, as such, nothing is novel because this is a very benign tumor, but the only message that I want to give is that these kind of patients require follow-up, because even though there are few chances of malignant transformation, but since a very close possible differential is choroidal melanoma, these kind of patients need supervision and they need to be under regular follow-up.
You said there are very less likely chances of turning it into a malignant tumor.
Yes, sir.
But if it turns, what are the changes which you will be looking for?
Sir, there will be a rapid growth, rapid increase in size of the tumor, and it will be associated with severe loss of visual acuity if there is invasion.
Thank you. Thank you, Dr. Subrajyoti. So now can we have Dr. Virendra Prasad? Yeah. So the topic is KF sign is a better confirmatory sign than serum ceruloplasmin in the Wilson's disease.
Hi, good morning, everybody. Now, I don't know how many people have seen K-ring, but it's not a very common thing to see. So my paper is, K-ring is rather a better confirmatory sign than a serum ceruloplasmin in cases of Wilson's disease. He is Samuel Alexander Kinnear Wilson, and contributors are a lot because it's not possible to see a lot of K-ring by a single surgeon. So Wilson's disease is uncommon disease, and it's not a rare disease. And the cases go undetected. That's why this, and because of lack of suspicion and lack of proper lab diagnosis. Our aim was to find out the relation between the density and the width of the K-ring versus the lab finding of serum ceruloplasmin serum copper, and response to the treatment was a decreasing K-ring. If you review the literature, there is inborn autosomal recessive with deficiency of alpha-2 globulin and ceruloplasmin, and results into the free copper and throughout the body. And in cases, it affects the liver, and the neurological deficiencies are there, especially the rigidity dysarthria, dysphagia, and dystonia is very, very important. The diagnosis depends on a CT scan, which shows the ventricular dilatation and hypodense area in the thalamus and basal ganglia. And the MRI shows face of giant panda, typical, appearance in the midbrain. And slit lamp examination shows K-ring. So this is a CT scan, and this is a giant panda sign. Giant panda looks like that. And urinary copper is always elevated in such cases. The copper excretion is more than 100 microgram. So this is a K-ring with magnification. This is K-ring, K-ring, K-ring. And you see the patients, look at the face of the patient. It's a typical, the presentation of the face. The patient is not happy. He's in agony, but then it's all stretched up muscles. And you see, he's in such a pain, and there's a psychological effect you can see. Again, the same patient, the other patient with the same kind of face. Look at the face, look at the rigidity, 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 rigidity. And look at the typical gait of the patient. So let's talk about the K-ring, which is located in the peripheral part of the descemet membrane and ends just in front of the Schwalbe's line. It does not invade trabecular meshwork. We have graded the K-ring. All suspected and new cases which were suspected to have a K-ring were sent to us, who carried all the informations about the lab. So we graded it to grade 1 was the top arc of the dense membrane was involved, and grade 2 was the inferior arc was involved, and grade 3 was all around it was involved as a ring, and grade 4 it was a wider deposition of the rings. Like this is the grade 1, this is the grade 2, this is the grade 3, and this is the grade 4 of K-ring. The severity of the disease, serum ceruloplasmin, and response to treatment was observed in relation to K-ring. 160, in our observation, 168 cases of Wilson's disease suspect, 158 were confirmed, 14 had normal serum ceruloplasmin level, but positive K-ring. 10 had low serum ceruloplasmin level, but no K-ring, and did not respond to the treatment. Grading did not match with the serum ceruloplasmin level, but with the clinical severity. A response to the treatment matched with decreasing grade of K-ring. Patient's own evaluation matched. In all cases where the patient improved with the treatment, there was sign of regression of K-ring, and 6 cases of KF without lab test improved with treatment. We have so many number of patients in different gradings. 18 cases of grade 4 K-ring and 6 cases of grade 3 K-ring. Patients succumbed to the disease because of the non-availability of the medicine and irregular dose. So we conclude that dystonia, rigidity, dysarthria, drooling, tremors, progressive chorioarthrosis, and behavioral and psychiatric manifestations enough to arouse the suspicion. Should be subjected to a slit lamp examination along with the lab investigation. Wilson's disease is commoner than what we think. Treatment should start if K-ring is present. Since 14 had normal serum ceruloplasmin level, but positive ring, and it responded to the treatment. Number 2, Wilson's disease, if it is below 10 microgram of ceruloplasmin, you confirm it. And since 10 cases had low serum ceruloplasmin level, but no KF ring, and it did not respond to the treatment. Since all cases showed decreasing KF ring with treatment, KF ring is a better confirmatory sign than serum ceruloplasmin in Wilson's disease. Thank you.
What is the duration between which you saw these 158 patients? What is the duration of the study?
It's a very long-term study. It's from 1994 till recently in May 2022. Because getting 168 cases is, I don't think so.
That's why I asked.
Yeah, it's very long. And there were so many contributors. All the neurophysicians and even the Kanki mental hospitals, they thought it's a mental case. They all referred the cases for the KF ring.
So was there an association with the symptoms also with KF ring, presence of KF ring, like the rigidity and other things? Was there any association? Was it checked?
Sir, as I showed you that there is a typical phases of the patient. There is a rigidity, there is a drooling, and the rigidity is so much that you cannot even, it is very difficult to put them on a slit lamp. Leave apart the gonioscopy. Gonioscopy is not possible. If some literature says that gonioscopy should be done, it is just not possible if it is a case of Wilson's disease.
But many times I think handheld slit lamp helps. Handheld slit lamp in case of rigid patients.
Yeah, slit lamp you can see the KF ring, but you cannot do the gonioscopy. What I'm saying is some say that gonioscopy should be done. It is not possible. It's just not possible.
For the benefit of audience, can you differentiate the clinical feature between arcus senalis and KF?
The arcus analysis in the upper part, and there's a typical yellowish discoloration of the endothelial part of the cornea in the Wilson's disease, and it is dense in the periphery, and becomes little thinner. It rarefies if it goes towards the center. I'm talking about the grade 4, because that will you'll be able to understand better. So it is very dense in the center. It spreads periphery and it spreads towards the center, and when it goes to the center, it keeps on rarefying itself. And sometimes people mistake it by the limbal yellow coloration of the limbal conjunctiva when it comes to the cornea. It's yellow, so people confuse it with that. So it is an inner part, and it never goes beyond the Schwalbe's line. It doesn't reach the trabecular meshwork.
Thank you.
Thank you
Thank
so
you.
much, sir. Now we have Dr. Harinder with ocular surface squamous neoplasm.
Good morning, everyone. Today I am presenting case report of ocular surface squamous neoplasm. OSSN is defined as slowly progressive benign premalignant and malignant in epithelial lesion of conjunctiva and cornea. Squamous carcinoma accounts 14% of the conjunctival tumor. OSSN most commonly start in the conjunctiva and extend across the limbus to the adjacent cornea. Risk factors include ultraviolet exposure, acquired immunodeficiency syndrome, xeroderma pigmentosa, human papilloma virus, mainly 16 and 11. It has been recognized that squamous neoplasma occur both in the form of invasive and non-invasive subtypes. Morphologically, it is classified into 4 types: fleshy, gelatinous, leukoplakic, and papillomatous. Most commonly is gelatinous types. The presentation varies from benign from foreign body sensation, redness, irritation, diminution of vision due to higher astigmatism or involvement of visual axis. The mainstay of treatment is complete surgical excision with 2 to 4 mm margins, clear margins. Now we'll come on case report. A 55-year-old male patient to the clinic with chief complaint of redness, foreign body sensation, mass in the left eye, associated with watering from last 1 month duration. The lesion was completely slowly progressive, associated with pain, redness, and appearance with tough top vessels, which are sentinel vessels without well-defined borders. There was no history of trauma, foreign body injury, and chemoradiation exposure and significant weight loss. No past history of diabetes mellitus, hypertension, and tuberculosis and other chronic illness. On examination, right eye is unremarkable with best corrected visual acuity 6 by 6. On left eye, this is the picture of left eye, a fleshy, highly vascularized, gelatinous, irregular mass extending from limbus to the temporal aspect of the left bulbar conjunctiva of size of 6.5 to 4.5 mm. And best corrected visual acuity in left eye also 6 by 6. On AIOCT shows thickening of the epithelial area in the cornea, just slightly 1 mm around center to the limbal. These are the blood investigations. All systemic blood investigation are normal. A presumptive diagnosis of OSSN was made. Patient was started on eye drop 5-fluorouracil 1% 4 times a day for 1 week, followed by drug holiday of 3 weeks. On follow-up after 4 weeks, vascularity was significantly reduced and seen on this picture, and size was reduced to 3.5 to 3 mm. After 4 weeks, patient was again put on 5-fluorouracil 1% 4 times a day for 1 week, followed by drug holiday for 3 weeks. On follow-up after 8 weeks, lesion was completely resolved and only slight vascularity was there, as shown on this picture. Now come on discussion. OSSN are rare pathological entity. These are most benign lesion having very rare risk of malignant transformation. It involves only basal epithelial layer or full thickness on epithelium, depend on the type of lesion. Breslow and Jacobi classify conjunctival intraepithelial neoplasm and mild, moderate, and severe dysplasia based on the extent on involvement. UVB light, which is important risk factor of OSSN, cause lesion by DNA damage and formation of pyrimidine dimers. Various study has shown that clear association between HPV and OSSN, particularly human papillomavirus 6 and 11, which form complex with the protein encoded by tumor suppressor gene in the host. The diagnosis of OSSN is mainly based on histopath findings. The treatment of choice is surgical excision, and presently topical chemotherapy is preferred as it is inexpensive, simple, and reduce the risk of limbal stem cell deficiency. 5-fluorouracil, mitomycin C, and immunotherapy is used. Most commonly used is 5-fluorouracil. 5-fluorouracil acts as specifically during S phase of cell cycle. Various study has been done regarding efficacy and safety of 5-fluorouracil, and it has been found that it is highly recommended in OSSN nowadays prior to the surgical excision. In my case also, there is almost complete resolution of lesion with 5-fluorouracil, which confirm the high efficacy of 5-fluorouracil in treatment of OSSN, as it has been found in various studies. Now come on conclusion. OSSN lesion of the cornea conjunctiva are uncommon but demand appropriate attention due to potential visual loss of systemic morbidity and mortality. Early diagnosis and treatment of OSSN is very necessary to prevent progression of the lesion from pre-invasive to invasive type. Newer modality of diagnosis allow non-invasive evaluation, which correlate with well histopath tissue diagnosis. 5-fluorouracil is highly effective and well tolerated as primary treatment for OSSN. Very study from 82% of tumor responding completely to the therapy. Also in my patient, also it is highly efficacious. These are my references. Thank you.
Again, OSSN, as we all know, is histopathology is the, and the treatments are also known.
Yes.
What is the message you want to give from your study?
The homotic message is this, sir. Nowadays we will not prefer surgical excision. We will go for chemotherapy first. In many publications they mention that nowadays we will use 5-fluorouracil on basis of diagnosis, on basis of AIOCT and clinical picture, sir. We will go for 5-fluorouracil. Sir, in this surgical excision, limbal stem cell deficiency was there. That's why, sir, we prefer chemotherapy.
So chemotherapy is
5-fluorouracil.
considered as
First line.
before surgical excision. That is the message.
In
Thank you.
surgical excision also, after some in 20% cases, we will go for chemotherapy with higher chance for recurrence. Sir.
You may need chemotherapy
Yes, sir.
even after surgical.
20% chances of recurrence.
Yes. Thank you.
Thank you.
So we now have Dr. Rolika with medullopithelioma of the ciliary body, enucleation versus conservation.
Just 1 second.
Which one? Next one.
Can we have the next presenter if she will? Dr. Sharmishta, if she will. So ocular, periocular tumors and tumor-like lesions in Western Odisha.
The next
tertiary
people
healthcare
have
center.
not come. We started 20 minutes late. We'll finish on time.
So we'll finish in 5.
Very good morning, the chairpersons and the august gathering. The title of my presentation is Ocular, Periocular Tumors and Tumor-like Lesions at a Tertiary Healthcare Center in Western Odisha in India. This shows a map. This is a map of Odisha showing the western 10 districts of Odisha. So we have got no financial interest or no conflicts of interest. To introduce, though cancer is the leading cause of death and is increasing exponentially, the incidence of eye cancers is as low as 0.5%. The methods were, it is a retrospective observational hospital-based study acquired from medical records, which was conducted from January 2017 to June 2022, which is a 5.5 years duration. The data was retrieved from of the 72 patients diagnosed with ocular and periocular tumors and tumor-like lesions from the medical records, and the inclusion criteria was all the clinico-pathologically diagnosed cases. The results, out of a total number of 72 patients, the mean age was 38 years, the male to female ratio 1:1.66, with 45 male and 27 female. This table shows in the age group of 0 to 10, there were 4 patients. The most common anatomical location was the eyelid. The most common surgical procedure done was direct excision. And the most common histopathological diagnosis was dermoid cyst. In the age group of 11 to 20, ocular adnexa was the commonest anatomical location. Surgical procedure done was direct excision, and it was again dermoid cyst. 21 to 30, it was adnexa. Direct excision was done, and oculosporidiosis was the commonest histopathological diagnosis. 31 to 40 years age group, it was the eyelid, where tensils was commonly done, and papilloma was the commonest histopathological diagnosis. 41 to 50 years, eyelid was the common anatomical location. Mustards was the surgical procedure mainly done, and the common was meibomian cell carcinoma. 51 to 60 years, eyelid was the commonest anatomical location. Mustards was the commonest procedure, and basal cell carcinoma was the commonest histopathological diagnosis. In more than 60 years age group, bulbar conjunctiva was the commonest anatomical location. Direct excision was done, and OSSN was the commonest histopathological diagnosis. In the histopathological types, benign tumors constituted 33%, that is 45.83%, and dermoid cyst was the commonest growth in the age group of 11 to 20 years. In the malignant tumors, 20 cases, commonest was OSSN, 11 cases in the age group of more than 60. Tumor-like lesions were 19. Oculosporidiosis is very common in our area. Hemangioma showed a common recurrence. So this graph shows the various types of surgery done, which included direct excision, tensils, mustards, cutler beard, anterior orbitotomy, lateral orbitotomy and exenteration. These are certain pictures of certain benign cases showing a dermoid, a papilloma, and a conjunctival retention cyst. This is a schematic showing the semicircular Bustard's flap, and these are certain cases. This is a case of basal cell carcinoma, which shows a Bustard's that is done pre and post-op picture with the histopathological diagnosis. This is a case of meibomian carcinoma, which shows a pre-op picture and during excision and a post-op picture. This is a Tenzel's flap. The schematic diagram usually involved, which is done for the upper lid tumors. And these are certain cases where the Tenzel's was done. So Cutler beard, where the large masses of the upper lid are undertaken for surgery by this method. So this is a procedure just after Cutler beards, and then we would call the patient after 2 months for the formation of the lid. This is a case of invasive squamous cell carcinoma. Again, we can see Cutler, but here we can see that the lid margin has been cut post-trauma after the surgery. This is another case where Cutler beard was done in case of malignant melanoma. Now here, this is a case which showed recurrence post-Cutler beard surgery. It was a case of meibomian cell carcinoma. Then these are certain cases, different types of OSSN shown, papillomatous, gelatinous, and leukoplakic. The lateral orbitotomy approach provides a direct and minimally invasive corridor to orbital apex, cavernous sinus, and middle cranial fossa lesions. These are two cases. One is lateral orbitotomy and the other is anterior. And these are certain tumor-like lesions. These are very common oculosporidiosis cases in our area. This is a case of exenteration which was done in post-COVID mucormycosis. And the study has limitations because study similar to Honavar et al. And Kalki et al. With large cohort of patients, hospital-based study with facilities for accurate diagnosis by a trained ocular oncologist, and patient representation from a diverse geographical area of India are the need for a thorough research. We had less number of cases and a small area. So my conclusion is, I have already said we had benign, malignant, and tumor-like lesions, and our area included more number of oculosporidiosis cases. So my take-home message is, we should have a better frozen section facility with improved training for ocular oncology and improved documentation and presence of a referral-based comprehensive ophthalmic oncology setup which can enhance the study protocol. Thank you so much.
Good compilation of cases. I think you have any question? Okay. Due to paucity of time, we'll go to the next presentation.
Thank you.
Thank you.
So I would like to invite Dr. Rajni Sinai. She is presenting on the clinico-epidemiological and demographic profile of retinoblastoma cases in a tertiary care center.
Good morning, everyone. I'm going to present my study on clinical epidemiological and demographic profile of retinoblastoma cases in a tertiary care center. I have no financial interest and no conflict of interest. Coming to introduction, retinoblastoma, it is the most common intraocular malignancy of childhood, and it represents around 3% of all childhood cancers. The incidence of retinoblastoma on a global scale is 11 per million children in 5 years and younger age group. In India, the incidence rate stands at 0.6 cases per 1 lakh children. There are an estimated 5,000 new cases worldwide annually, with India alone contributing to 1,500 to 2,000 cases, that is 33% of the global burden. It is bilaterally about 25 to 35% of cases, and the average age at diagnosis of retinoblastoma is 18 months, unilateral cases being diagnosed at around 24 months and bilateral cases before 12 months. Objective of my study was to determine the burden of retinoblastoma cases at our center, its clinical profile, and its association with demographic factors. It was a hospital-based observational cross-sectional study done at AIOCMTC1 Patna. Ethical clearance was taken, and study population comprised patient presenting with leukocoria, that is white pupillary reflex, to our OPD, and confirmed for calcification on ultrasound B scan for extraocular or extracranial extension, as was confirmed on MRI, brain with orbit. Inclusion criteria was all referred cases of suspected retinoblastoma and newly diagnosed cases at our center of retinoblastoma. And exclusion criteria was other ocular malignant conditions such as rhabdomyosarcoma, leukemia, etc., and cases of leukocoria other than retinoblastoma, and all those who were not willing to be under the study. These were few clinical photos showing white pupillary reflex, and this extraocular, this extraocular extension of tumor presenting as proptosis. Coming to result, a total of 32 patients, that is 38 eyes, were identified with retinoblastoma out of 71,000 patients seen during the study period, giving the burden of disease to be 0.045%, that is 4.5 per 10,000 patients. Out of 32 patients, 68.75 were male and 31% were female. The male to female ratio was 2.2:1, and disease was unilateral in around 81% and bilateral in 19% patients. Mean age of patients at presentation was 30.86 months, and family history of retinoblastoma was seen in one case, and rest were all sporadic cases. History of consanguineous marriage was present in 4 cases, that is 12.5%. Coming to clinical profile, most of the patient presented with leukocoria, which was around 81.57% patient, followed by squint, proptosis, and orbital pain. Coming to demographic distribution, most of the patients presented in 24 to 48 months of age group, which was around 56.25%, followed by less than 2 years, which was around 31.25%. And we already saw that it was more prominent in male, and laterality, we had unilateral cases more. And most of the people belong from upper lower socioeconomic status according to modified Kupusomi classification. This is geographical distribution showing different districts of Bihar from where patient reported to our center. Most of the patients were from Purbi Champaran, followed by Purnia, which was around 15.62% from Purbi Champaran and 12.5% from Purnia. Coming to grouping of the disease, it was based on international classification of retinoblastoma, and most of the patients present in advanced stage, that is group E, which was around 66%. Coming to discussion, the burden of disease in our study was 0.045%, that is 4.5 retinoblastoma patient per 10,000 patient, though it is very less in frequency when compared to other diseases of the eye, and it was similar to a study conducted by Subha et al., which had less incidence of retinoblastoma when compared to other diseases of the eye. In our study, 81% patients belong to lower socioeconomic status, which was similar to study done by Sahu et al. And Abramson DH et al. In the present study, family history of retinoblastoma was present in one case, which was similar to study done by Sethi et al., which had 3% cases with positive family history. Coming to sex distribution of retinoblastoma patients in different regions of India, in our study, it was male predominance, which was almost similar to study done at different places like Nagpur, PGIMR, AIIMS, and Mumbai in India. And mean age of diagnosis was almost comparable with other studies done at different places. Now coming to comparison of presenting symptoms, most of the patients in our study presented with leukocoria, which was almost similar to studies done at different places of India and Pakistan, China, and Turkey. Coming to grouping of disease, we had more of the patients in group E, that is advanced disease of presentation, which was similar to studies done at AIIMS, PGIMR. A limitation of my study was a small number of patients taken in the study makes it difficult comparing our result with those from other centers with larger series. In this study, all patients were not followed up, so survival rate analysis was not done. Incidence and prevalence was not calculated as it was a single center study, and genetic analysis of patients were not done. Coming to conclusion, based on our finding in the study, we conclude that leukocoria was the most common presenting symptom. Male predominance was seen in our study, which may be because female child is often a victim of neglect. Cases reported mainly from lower socioeconomic strata with advanced stage of disease presentation, which can be explained by the fact that parents and relatives are not aware of the disease due to lack of access to healthcare facilities, ignorance about early sign, illiteracy, poverty, lack of trained personnel, and inadequate infrastructure at many healthcare centers. So there is a need for creating awareness so that tumors may be detected at an early stage, followed by timely referral, proper counseling of parents and relatives about the nature of the disease, importance of early treatment, available treatment options, and the need for follow-up is important. So as we know, RB accounts for a high tumor burden in developing countries, and the prognosis is closely related to the socioeconomic and cultural profile of the population. These barriers can be overcome to a certain extent by proper counseling of parents and their relatives, providing free of cost treatment to patients from lower socioeconomic strata. These are my references. Thank you.
You. do you have any adult patient with retinoblastoma?
No, sir. Highest was 7 year of age group, sir.
Okay. Thank you. Go to. We'll go for the last presentation. This is the last presentation.
Good morning, everyone. I'm so sorry for the technical glitch. I apologize and thank you for the patience. So I will be talking on medullary epithelioma of the ciliary body, enucleation versus conservation. We have no conflicts of interest to declare. So basically, the patients often present to us with leukocoria, somewhat like this kind of a presentation. And we are often told that the differentials are congenital cataract, retinoblastoma, Coats disease, and the list goes on. But nobody ever speaks to us about medulloepithelioma, and yes, it is quite an important differential of leukocoria. It is a rare, non-hereditary neoplasm of childhood arising from the primitive medullary epithelium, mostly involving the ciliary body. 75 to 90% of the tumors present in the first decade, and it is often misdiagnosed, as I just mentioned. The treatment includes cryotherapy, plaque brachytherapy, external beam radiotherapy, local resection, enucleation. And local tumor resection has 50% recurrence in these cases. And as per literature, enucleation is often required as primary or secondary. So eventually, if you're going for the radical approach, we thought, why not look for a conservative approach? So we went to the literature. As per the literature, chemotherapy has been attempted in 2 of these studies, but it has been highlighted in a very important review of literature that the role of systemic chemotherapy is not yet well established and it remains to be further explored. So we thought, why not? Let's explore. And as we had to take all the cases, we went ahead and conducted a retrospective interventional case series of 19 eyes of 19 patients with clinically confirmed medulloepithelioma, biopsy proven, treatment naive eyes. And exclusion criteria was baseline metastasis or loss to follow-up. We saw that the median age was 24 months, the range was 1 month to 66 years, and only 2 were referred with correct diagnosis, and I hope you understand the highlight and the importance of this sentence. The patients presented mostly with leukocoria, 63%. Neovascularization of iris was seen in 53%, secondary glaucoma. Vascularized lateral membrane was seen in 26%, and anterior chamber mass, which is like quite evident in the second picture as you can see over here, was seen in 21% cases, and lens subluxation is quite an important one because the tumor pushes the lens aside and therefore it causes subluxation. Ultrasound biomicroscopy plays a very key role over here because you can see intratumoral irregular cystic areas, and in our study we saw basal diameter of maximum 16 and basal thickness of maximum 8 mm. So medulloepithelioma treatment is basically divided in these subsections, and I'll be taking them one by one. So we observed one of the cases which was basically a tumor which was less than 6 clock hours, and in fact it was only in 1 clock hour and the patient is doing well even now. In the cases which were surgical intervention, fine needle aspiration biopsy plays a key role, which we did in 42% of the cases, which showed pseudostratified primitive neuroepithelial cells surrounded by hyaluronic acid-rich hypocellular stroma. And immunohistochemistry also plays a very important role in confirmation of these diseases. So primary enucleation was also done in our cases, 53% cases. But these were the cases which had extensive involvement, more than 6 clock hours, neovascular glaucoma. And these patients were mostly teratoid or non-teratoid, benign or malignant, based on the Zimmerman et al. Criteria. And 2 cases received adjuvant radiotherapy. These are the ones with scleral invasion and extraocular extension. So now comes to the conservative part, and that is 37%. And it's not a very small number when we look at the cases with less than 6 hours involvement. So here you can see 78% were still treated conservatively with chemotherapy with vincristine, etoposide, carboplatin, and cyclophosphamide combination. And 2 of these cases required secondary plaque brachytherapy. So you can see over here that post-chemo, the tumor has responded very well. So we can actually contradict and go back in time and say that yes, the tumor does respond to chemotherapy, and with plaque, we are kind of ensuring that it does not come back. And over here, we have seen excellent results. The next part is plaque brachytherapy, which has also shown excellent results in less than 6 hours. And with all of these things put together, we can say that 100% eye salvage can occur in these cases with no local tumor recurrence or systemic metastasis at a very long follow-up as seen over here. So in our study, we can say that secondary enucleation was not done in any of the cases. We were able to achieve conservative management in the cases which were less than 6 clock hours involvement with complete 100% live salvage. So to conclude, it's a rare, non-hereditary neoplasm with arising from primitive medullary epithelium, presents in first decade. Look for intratumoral cysts. Cystopathological diagnosis is advocated. Timely, accurate diagnosis is important. Regional and distant spread can be avoided. Scleral invasion, if present, can be dealt with adjuvant radiotherapy, and conservative management is what we advocate with primary chemotherapy and secondary and primary plaque brachytherapy in cases which have less than 6 clock hours involvement. So thank you very much for your patience. The most common misdiagnosis, sir, was retinoblastoma.
So the message is you should also consider medulloblastoma in case of white reflex.
Yes, sir. And it can be dealt with conservative management as well, because in earlier times it was directly taken up for enucleation, so we can provide globe salvage and vision salvage in these cases.
What is the longest follow-up of patients who are on conservative management?
So in the longest follow-up, we have had 12 years.
Thank you.
The case which is having 12 years of follow-up is like,
Sorry,
what is the outcome into that patient?
the vision salvage is there,
Vision
sir.
salvage
Yeah,
is
yes,
there.
sir.
There is no recurrence.
No.
Thank you. Good.
Since you asked what is the most common differential, most of these patients usually present as pediatric glaucoma. Because this is a tumor which is hidden near the ciliary body, they often present with pediatric glaucoma, increase in intraocular pressure, mostly misdiagnosed and not diagnosed as a lesion sitting in the ciliary body. And they have this front of vessels which goes as a sheath behind the intraocular lens. Unfortunately, most of these patients undergo trabeculectomy and trabeculotomy. First, intraocular procedures are very, very common in medullary epithelioma. So seeing the sheath of vessel, we have to always look for something hiding inside the ciliary body, and UBM is the best to help you.
That's why IC, even in cases of IC, where the anterior chamber is little uneven, one need to do the UBM. Right. Just to get feel something is not wrong behind.
Thank you for your inputs and good cases. Thank you all.